So, per request, we're going to go over flow volume loops and capillary fluid exchange. I literally just finished this, so not entirely sure how complete it is. Okay, so here we have a normal flow volume loop. This represents inhalation, and the bottom here represents exhalation. Simple enough. However, I want to ask you guys really quickly, what is the vital capacity? What is VC? You had to explain it to a brand new student. Well, okay, let's start with the What is the total lung capacity? What's the total lung capacity? Let's start there.
The amount of air you can maximally inhale and exhale.
Well, that's actually vital capacity.
Total would be the amount of air that's in your lungs after you breathe. Like maximally breathing.
Mm-hmm. So, since we have a discrepancy, we're going to go over these really quickly. So, our vital capacity, like Divya said, is the amount of air total if we were to take the largest breath that we possibly could and then exhale to our maximum exhalation point. That's our vital capacity. Our residual volume is the amount of air left over in our lungs after we have done the most absolute exhalation possible. And then our total is the combo of the vital capacity and the residual volume. Okay? So just to reiterate, a capacity is a combo of volumes, and a volume is just an independent portion of the lung volumes. So whenever you see a capacity, that means the combination of something. Okay? But normally, vital capacity, total lung capacity, and the residual volumes are the most important as far as interpreting PFT data. So going back to this guy, our vital capacity here represents the total amount of air we can inhale as well as our maximal exhalation. Although normally you and I aren't doing full inhalation and total exhalation, but when you're doing a PFT study, that is what they're looking at. And also, keep in mind this residual volume. So anyways, what we're looking at here is that in this particular individual that we're looking at, they have a lung volume maximum in their total lung capacity. Again, they have about 6 liters of air, and it's representing here that the residual volume is a little less than 2, about 1.5 liters, which is typical of the residual volume. Okay, this is a normal pressure flow volume. So now we're going to look at an obstructive disease. Can anybody give me an example of some obstructive lung diseases?
COPD.
COPD.
Bronchitis.
Yeah.
Asthma.
Yep. Asthma. Got one more.
Emphysema.
Yeah. Emphysema
is restricted. Yeah. It's like it goes both ways or something.
Yeah. Emphysema and COPD can go that way. We're going for bronchiectasis.
Yes, bronchiectasis.
So COPD, emphysema, and asthma, all kind of very similar. So what is the issue with all of these paths if it's an obstructive disease?
You have air trapping?
Air trapping, right. So that means that we have difficulty in exhaling our air. So, compared to the normal flow volume loop, which we see here, obviously, we don't have our little lines that tell us our TLC, our RV, and our FC, so or FVC. So, what are the predicted values for those? Let's say TLC.
8.5-ish.
It's going to be increased.
That's right.
How about our residual volume?
Increase.
All right, because we got air trapping. So that means when we're done exhaling, we have a lot more air that is still trapped inside of our lungs. And then functional capacity, functional vital capacity.
Decrease.
It could be normal or decreased. Excuse me. Okay, so having said that and looking at this flow volume curve, now in a test question, they probably won't give you this. They won't give you the normal loop and then show you this, but what they will do is give you a vignette, probably telling you some guy has been smoking for 30 years and he's got the barrel chest and he's got, dyspnea on exertion, and then they'll give you this graph and they'll tell you something, what type of volume is it? And the reason you can tell that it's an obstructive disease, A, you can see here that the expiration of this. Oh, okay, yeah. So sorry, I made a mistake. This is inspiration. That's expiration. My bad. Anyways, that they can't inhale or exhale quite as maximally as you or I can because we are normal, healthy people with pink lungs, and these guys have the obstruction. Even though they have hyperinflated lungs, they are not able to fully get as big of a breath as we can, whether it's due to the trapping or the damage from emphysema or from the expansion of their bronchi in bronchiectasis. So what you're going to have in expiration, this is pathognomonic for a flow loop in obstructive diseases, is this little dip that you see here, which you don't see in a normal volume, and as you'll see in restricted, you don't see it there either. But having this little dip is quite unique to obstructive, and that's because they're having issues with expelling that air, and it's not a steady exhalation after their FEV1. It's decreasing much more dramatically than a normal person. And as you can see, there are shifts to the left, and that's because we're increasing our total lung capacity as well as we're increasing residual volume. So our lungs are bigger, but it's due to the fact that we have more air trapped inside, not that we're able to inhale more air. Does that make sense to everybody? Okay. So now in restricted lung diseases, we've got loops that shift to the right. So can anybody give me some restrictive lung diseases?
Emphysema.
Pneumoconiosis.
Yeah. Ooh. Yeah, pneumoconiosis,
Sarcoidosis.
sarcoid, right? There are two others that are systemic diseases that cause restrictive. Sarcoid was one.
Alpha-1 antitrypsin. No.
Pregnant?
Well, no, because alpha-1 antitrypsin causes emphysema, and emphysema is more of an obstructive.
Yeah.
So, what did you say, Yash?
Wagner's granulomatosis.
Yes, that one's one. Wagner's. Wow, that was really bad. Sarcoid. We've also got hemochromatosis.
Pulmonary fibrosis.
Yeah. Let's put IPF for that one. You also have amyloidosis. You guys said pneumoconiosis. So anyway, restrictive lung diseases, and the issue with this is the opposite. Instead of being able to hyperinflate, we have decreased elasticity, and these guys can't inflate at all. And that's again IPF, interstitial fibrosis. It's literally the parenchymal tissue of the lung is hardening and becoming stenotic, so you're not able to fully inflate. So because of that, these guys are taking shallow, decreased breaths, and their residual volume can be decreased, and their total lung capacity is decreased, and essentially all of their vitals are decreased except for, well, actually, never mind. Not that yet. I'll bring it up in a bit. Essentially, all of their flow volume values are decreased. However, and actually, this is in my first aid 2015, but it is not in the new first aid, or in 2017 at least. So they got rid of this and replaced it with these doodads. But I like this one because this is showing the relationship of FEV and FVC. So we already mentioned that the FVC is the functional vital capacity. This is the amount of air if we take a full breath in and exhale absolute maximally. What's our FEV1 though? What does this mean?
Amount expired in 1 second.
Right. We exhale the majority of our exhalation within the first second, and then the rest is kind of trickling down. But normally we have an FEV1 to FVC ratio of 80% or greater. Now, in obstructive lung diseases, we are going to have a decrease in our FEV1 to FVC ratio. And again, that's because we have an increased residual volume, but we have a decreased functional vital capacity. So if we are decreasing the denominator, we're decreasing the denominator as well. Before I use funky term, we're decreasing both, except our FEV1 is decreasing much more than our FVC. That's why we're going to have a decrease in the ratio. Whereas in restrictive diseases, both of them are decreased, but it's more a unifying decrease. Both of them are decreasing in the same amount. So you might have an elevated or normal FEV1 to FVC ratio. So one that isn't mentioned in first aid, but I got a UWorld question on it. I think it was the Step 2 Q-Bank, but it was so I'm going to use the normal. It was a pulmonary function curve that looked like this. And the vignette described a boy that went to dinner with his family, and he had some shellfish, and then started developed a rash, shortness of breath, and then they showed this function curve, and they were asking what was the mechanism that underlied this function curve, and he was having an anaphylaxis or laryngeal edema. And so essentially what they're trying to say is if you have some sort of airway obstruction, you can have very shallow inspiratory and expiratory on your inspiration and expiration on your flow volume curve. So that's more of just like a physio question that they want you to know that you'd be going if you were having some kind of anaphylactic attack, or actually they could probably use a question or use a flow volume like this if you're having a panic attack maybe too. So just to keep that in mind as one that's the only time I've seen that flow volume curve. Okay, so any questions on flow volume loops or obstructive, restrictive, lung diseases, anything like that? So again, just to review, normal FEV1 FVC ratio 80 or above. Obstructive, you're going to have a decrease in your FEV1 FVC. And restrictive, you're going to have normal. It's because everything is uniformly decreased in the restrictive. Okay, so now we're going to talk about capillary fluid exchange. So what the basic principle here to understand is you have 4 different numerical value. You have 4 different, what's the word I want to use here? Entities? No, that's not it. Variables, that's the word. You have 4 different variables that are going to essentially come up with the ultimate equation of capillary fluid exchange. We have this because we need to exchange, whether it be proteins, nutrients, fluids, blood, cells, WBCs, cytokines, whatever. They flow in and out through these capillaries, and based on the pressure that is associated along these vessels is going to judge whether or not it's going to be coming inside of a capillary space or out into the interstitial space. So the 4 players that we have here are the osmotic pressures, which are represented by the, let's try that. Represented by the capital P's are the hydrostatic pressures. That means literally the pressure created by the fluids in their associated place. So the C represents the capillary, and the I represents the interstitial fluid space. So this would literally be the fluid pushing towards the capillary and the fluid in the capillary pushing out towards the interstitial space. Then, with the pi's, this represents oncotic pressure. What does oncotic pressure mean?
Protein.
Right. So if you have a protein, it has a charge to it. If you have
Negative.
Proteins, are they negatives?
Yeah.
Okay.
Albumin albumin protein has negative charge.
Correct. Okay, so the negative charge is going to be on the inside, and the positive charge will be the interstitial fluid. And so,
or you can think of it as albumin is negative charge and the basement membrane is negative charge, and so they repel each other, so it can't leak out unless the whole podocyte stuff happens to allow leakage of protein.
All right, there you go. So, so when we're talking about oncotic pressure, it's the pull. So hydrostatic is the pushing of fluid out, away, whereas oncotic pressure, the proteins pull fluid towards each other. Okay, and you can visualize this by just looking at this. You have the P's, the arrows are pushing away from the P's, whereas the oncotic pressure with the pi's are being pulled towards the pi's. So, it's a lot from, this is all the first aid section, but this is just to overview and show you the equation. So again, just reiterate, the P's stand for the pressures, interstitial and capillary, whereas the pi's represent the oncotic. Osmotic, oncotic pressure, same thing. So this is the equation. You're going to have the PC minus the PI minus the pi C and pi I. So it's a lot of subtraction. Okay? And then based on whether or not oncotic pressure or hydrostatic wins out, is going to tell you which way the fluid is going to move. Is it going to go out of the capillary, or is the fluid moving into the capillary? So, obviously, the biggest player as far as pathology goes is when we're talking about edema. There are a bunch of different ways that edema can occur. And obviously, the number one would be if you have an increase in hydrostatic capillary pressure. You just have so much that it's popping out. And right here, like I have the example, heart failure. You've got way too much heart, decreased cardiac output, fluid backing up. So if you got a lot more fluid in here, eventually it's going to start leaking out. Pretty self-explanatory. You could also have a decrease in the plasma proteins. So basically, you have a decreased pull into the capillaries, which is going to cause leaking. So we can have this in nephrotic syndrome, liver failure, protein malnutrition. Why might liver failure cause?
Because, like, if you have cirrhosis, you're not making proteins.
Boom, proteins are made in the liver. Okay, so you could have increased capillary permeability. So that's just literally, as far as the equation goes, it's an increase in this constant variable, but increasing in protein permeability, so you can have infections, toxins, burns, because in burns you're going to have a huge decrease actually in both proteins and tissues, so you can have increased capillary permeability, and sepsis or shock, those can cause increased capillary permeability. And then an increase in interstitial fluid colloid osmotic pressure. So basically an increase in pi I. So you're going to have more of a pull towards the interstitial fluid. And the example for that is lymphatic blockage. So you're just going to have an increase in proteinaceous proteinaceous particles in the interstitial fluid, and the charge from those extra particles is going to pull fluid into the capillary space. And I believe lymphatic blockage, what type of edema would a lymphatic blockage cause? Be a non-pit. Normally, like a heart failure, that's normally a pitting edema. But when you have lymphatic blockage, it's such a pull, and it has such a proteinaceous what's the word? Proteinaceous feel to it, whatever nature to it, that it doesn't pit. It pops that right back up. Okay, so any questions about the capillary fluid exchange? Essentially, as far as the vignette goes, the most likely thing that they would do is if you were to have to do an equation, they would give you all four of these values. You'd have to plink it out, and then the answer would probably ask you, are they going to have edema? That would probably be a way that they do it, or they'd give you values and tell you that this person has edema, and they might ask you what is a possible mechanism by which they have said edema. Because you burn victim, do they have liver failure? You know, why does this person have leg swelling? Any questions? Okay, got a couple questions for us now. So we have a 73-year-old man who has AFib and has been treated pharmacologically for 10 years. He presents to his primary care physician complaining of generalized dyspnea. Pulmonary function tests show forced expiratory volume in 1 second. The FEV1 and FVC capacity are both less than 70% of the predicted value, with an FEV1 to FVC ratio of 81%. The flow volume curve is shown in the image, which is not here. Which of the following is let's just say that is this guy. Hey, look at that. Which of the following is a possible etiology of this presentation?
B for boy. Amiodarone.
Right. Amiodarone. And how used. So, why would what do we have here? What is
Pulmonary fibrosis.
Okay, pulmonary fibrosis. What gave you the tip off?
The ratio.
Okay.
The patient has a fib, so he's taking some kind of drug that's causing it as a side effect.
Oh, you're right. So we have a normal FEV1 to FVC ratio, but it even tells you here both of those two variables are both less than 70% of the predicted value. So if we have both FEV1 and FVC both decreased, but we have a normal ratio, then we're talking restrictive. And, okay. And amiodarone, we know, causes a bunch of adverse side effects. What kind of side effects can amiodarone cause?
Hypo or hyperthyroidism. You always check your PFTs, LFTs, and TFTs.
Oh, there you go. What about skin manifestation?
Yeah, the Smurf skin or photosensitivity. Mm-hmm.
QT prolongation? Oh, okay. Anyway.
Yeah. Yes.
Okay.
Yeah,
So,
it's class 3, so yeah, Torsades.
Okay. So yeah, amiodarone, interstitial pulmonary fibrosis, which will lead to a restrictive presentation on a flow volume curve. Okay, good. Next one, we have a 66-year-old man with a history of myocardial infarction presents to your primary care office with complaints of dyspnea on exertion and swollen feet and ankles. On exam, you note an elevated JVP and 2+ pitting edema of the bilateral lower extremities. What is the most likely explanation for this patient's lower extremity edema? Increased capillary pressure, decreased plasma protein, increase in capillary permeability, increased colloid osmotic pressure, increase in interstitial fluid pressure.
Increase in capillary pressure.
Yeah, I'm going with that as well.
Boom! Increase in capillary pressure. So let's just go over the other ones. So we had a decrease in plasma proteins.
Nephrotic cirrhosis.
Right. So if we had a decrease in plasma proteins, that's a decrease in this. That would cause, decrease in plasma protein, that would cause things to go in, not out. If we had,
I guess I kind of think of it as okay, sorry, when I was studying it, I was kind of thinking of like that protein sucks the water.
Yeah, exactly. That's exactly how you can think of it.
Yeah, so it also kind of makes sense that way.
Yeah. So
so wherever the majority of the protein is, so if it's being lost, I guess it's clearly not, it's outside. So
right. So you can so just going through the others, you can increase in capillary permeability. Yeah, but this guy has an MI, not something that's going. He's not like toxic or anything. Nothing to cause an increase in capillary permeability. Increase in colloid osmotic pressure. That would draw fluid into the capillaries, not out of them. And then an increase in interstitial fluid pressure. Again, that would be causing fluid to go back into the capillaries, not out. So increase in capillary pressure is going to cause fluid to spill out of the capillaries. And that's all I got for y'alls.